welcome to the Gus Alva Perspective. We get an opportunity today to speak with Childress, a world-renowned expert on ADHD and autism, who practices out of the Las Vegas area. And what a pleasure having you here with us.
Thanks. I'm excited to be here.
Phenomenal. Well, you know what? We're talking about the Southern California Psychiatry Regional Meeting, its third year from its inception point. And the neat thing is that I know that you're going to be involved with session 4, which deals with ADHD, and session 5, which deals with sleep disorders. And I was hoping, Anne, that you might be able to shed some light regarding the presentations that you are going to be involved with. And maybe one of the things that we could start with is how you sequence stimulants against non-stimulants, whether that be atomoxetine, viloxazine, alpha-2 agonists, and what do newer formulations and delivery systems meaningfully add for patients?
Lots of stuff to unpack there. I need, wow, more than just a couple of minutes to talk about that. But the American Academy of Pediatrics, if we're talking about kids, we do have guidelines, US guidelines for kids. And what they recommend is that you start with an FDA-approved medication. With that being said, I usually start with a stimulant after talking with parents. However, if they say, you know, we have Uncle Clem lives with us and he has a history of substance use disorder, or I just don't feel comfortable starting my child on a controlled substance, that's absolutely fine because we have the alpha-2s that are approved, and we also have atomoxetine and viloxazine, the non-stimulants that are approved. If all is equal, I'll probably start with the stimulant. In the younger kids, we have more evidence to start with methylphenidate. However, about 80% of people respond to methylphenidate or amphetamine. So if somebody doesn't have a good response or they have intolerability to methylphenidate, we can pop right over to amphetamine. That's what I do with kids. What do we do with adults? Well, there are guidelines other places in the world, but there aren't any guidelines in the US for adults. However, I'm the past president of the American Professional Society of ADHD and Related Disorders. And under my tenure, folks got together, the experts got together, and we invited a number of people to form a committee and put guidelines together for adults. And I'm excited to say that that's probably going to come out either at the end of this year or early next year. So we'll have some more information. What do? I usually start with a stimulant with adults, again, unless they have some other reasons that they're talking about. They don't want a controlled substance. They're worried about losing weight. They may be drug tested at work. They may have somebody in the family, or they may have a history of substance use disorder. And so then I would start them on a non-stimulant. But a lot of it has to do with the patient's preference.
I love it. That was really comprehensive. Thank you, Anne. Here's another one that might be a little interesting. In regards of lasting advantage, do we have adequate long-term data on cardiovascular safety, growth effects, and the durability of functional benefit that we, scope for our patients with ADHD?
Let me start with durability, because treating ADHD in childhood doesn't make it go away. And I think of ADHD in the same way I might think of diabetes. If you stop taking your insulin, your blood sugar is going to get out of control, more than likely. And for a lot of people, that is what happens with ADHD. You stop medication and symptoms come back. Very few people have symptoms that go completely away. And you and I are old enough to remember that we thought that ADHD went away as you grew up. You grew out of it. And during my fellowship, I only treated one adult with ADHD. I know. And I've made a career off of doing clinical trials with adults with ADHD and also treating adults with ADHD. So we're getting a lot better at diagnosing and treating. Effect is not durable, but the good news is if medication has worked for people before and they stop it, because they do, people with ADHD aren't good about staying on their medications, but the good news is we can get them started back on medication and their symptoms will respond.
That's awesome. That is wonderful, Ann. Now let's shift gears a little bit and talk about sleep disorders, which to a degree also kind of touches on what we've been speaking about with ADHD, particularly with psychostimulant use, right? Oftentimes the things that we are looking for is maybe not sparking anxiety, increased heart rate, appetite suppression, but certainly sleep suppression can be an issue. Walk us through your typical regimen of dealing with insomnic issues in patients, maybe initiating with kids and then, thinking about the adults that you've treated as well.
Sleep disorders are common in patients with ADHD, both in children and adults. In children, whether they have ADHD or not, we do not have any medications that are FDA approved to treat insomnia, to treat sleep disorders. So what we really want to start with, especially for the kids, is we want to start with some structure, some cognitive behavior therapy. And with the kids, we may work with the parents more, helping them get into a nice bedtime routine, taking those electronics away, letting them settle down and get ready for sleep. And it's interesting because I'll still have people that are okay. We're still having a lot of trouble with sleep. And I can remember I was doing a sleep study a few years ago with kids with ADHD, and they had to go to the sleep lab. And I can remember one little guy, he just bounces in his pajamas with his teddy bear, and he had no intention of going to sleep. Apparently had horrible sleep at home, just couldn't get to sleep. And in about 15 minutes, even plugged in with all the stuff on his head in the lap, he was out. So I became a huge believer in behavioral treatment. Now, if that doesn't work, we do have some data with clonidine. We don't have any double-blind data with it that it helps, but there's some old data actually all the way back from the early 2000s and late 90s. We do have some double-blind placebo-controlled data with melatonin. And one of the things I love about the study, it was a study that Margaret Weiss did, is that she actually made them go through behavior therapy first. And then if they didn't respond, they could get melatonin. And melatonin was helpful. The problem with melatonin, as you know, it's not a prescription. So you're not sure exactly how much you're getting when you're getting it over the counter.
Got it. Well, Ann, you know what? Your insights are phenomenal. And we're so happy to have this little bit of a snippet, a little teaser of the thematic that we're going to be involved with you over the Southern California Psychiatry meeting, which we're particularly enthused about. So thank you again very much. And I hope you have a phenomenal rest of the day. Really appreciate your time, Ann. Thank you.
Thank you.